Good morning, everyone. My name is Don Mathanga, as Bill said, and I'm with the Kamuzu University of Health Sciences. Previously, it used to be called the University of Malawi, but due to the linking, now it's called Kamuzu University of Health Sciences. For those of you that may not know Malawi, maybe just a brief description of Malawi. It's a small country located in Southern Africa. It's embedded between Tanzania, Mozambique, and Zambia, with a population of about 20 million people. Everyone is at risk of malaria in this country, both in the rural areas and in some urban areas too, because we've been able to demonstrate that transmission actually does take place in some urban centers. In 2020 alone, we had about 4.4 million cases, which resulted in 7,000 deaths across the country. The key interventions in Malawi include ITNs, of course, which are usually distributed through some mass campaigns, the last one being 2021. Another intervention is intermittent preventive treatment in pregnant women, which is provided through the antenatal clinics. And of course, case management for those that are sick and are visiting static clinics. But of late as well, there's been a lot of village clinics that are being opened in order to increase access to treatment within the country. There is very limited IRS that is provided to just a few districts within the country by PMI. All right, so Malawi is one of those countries that has had new interventions come on board the last 4 to 5 years. RTSS was introduced within the country in 2019 across 9 districts as part of the WHO evaluation. So Malawi happens to be one of the 3 countries that have provided data actually, which has led to WHO now recommending that this vaccine be rolled out to other, be scaled up in other countries where malaria is endemic. Of course, we also introduced, I think in 2018, PBO nets, first introduced as a power distribution, and then later on through mass campaign distributed across the whole country to all households that were eligible to receive nets. I mentioned these 2 new interventions because they feature quite highly in our ICEMR. And as my colleagues talk about the science, I think you will get to hear about RTS, PBO nets, and how that is interacting with the other interventions that are on the ground. So just as a summary for the first ICEMR, Malawi mentioned that this is the second round of the ICEMRs, but in 2010, we were also a recipient of the first ICEMR. Basically, that ICEMR is the one that informs us this current ICEMR. The main objective for that one was really for us to be able to characterize the changing epidemiology of malaria in Malawi, and how that was affecting actually the burden of malaria disease and reservoirs. Key findings that came from there that I think you will kind of hear quite a lot as we present the Malawi ICEMR is that in Malawi, interventions, especially bed nets, coverage is quite high. Bed nets, IPTP, or even in some cases, I would say case management as well. Coverage is high, but despite that, we still have a high burden of malaria in Malawi. So I think that was a key finding for us, and that informed quite a lot of the science that we are actually undertaking in ICEMR 2. The second thing that we came out with is that school-aged children are an underserved risk group, most likely acting as well as the reservoirs for transmission within this setup. So what are the major scientific questions for us for this ICEMR? The first one is really for us just to say, why is malaria so stubbornly entrenched in Malawi, despite the rollout of bed nets, the rollout of IPTP and case management? Is it that the bed nets themselves are failing? or not, they're not doing their job very well. So you get to hear quite a lot about the work that we are doing around bed nets. Is it insecticide resistance, and what kind of an impact is insecticide resistance actually having on Anopheles vectors, and maybe even the bed nets themselves in terms of effectiveness. We are also interested in just looking at transmission. Who is transmitting more malaria within the country? Is it school-aged children, or is it under 5 children? What is happening with those that are usually asymptomatic, and what is their role in terms of transmitting malaria? We are also interested in looking at environmental factors in this, and how that maybe has maintained vector abundance and allowed that even interventions that we are providing don't work very well, because we still have quite a lot of Anopheles mosquitoes. How do these more common risk factors interact with other social, economic, and behavioral drivers? And what is the impact of the new interventions that are coming in? So the RTSS, for example, and the PBO nets, all of them were being looked at to just understand why we still have so much malaria despite these new interventions, all the old interventions being rolled out and scaled up within the country. Another question that we are very much interested in, and this is more a pathogenesis one, is just to start understanding why is it that certain children, when they get malaria, they are infected with the parasite, they stay okay and are asymptomatic, but others will progress to having a clinical disease. And others will actually go ahead and even have life-threatening cerebral malaria or anemia. So it's starting to understand that within the Malawi ICEMR, because of the high death rates that we still see from malaria within our setup. So these are the two main questions. Why is malaria so stubbornly entrenched in Malawi, and which patients are at risk of progressing to severe life-threatening malaria, and why? So we have got 3 projects that are going to be presented. The first one is basically looking at the role of ITNs in malaria control. My colleague Charles Mangani is going to do that. The second one is basically looking at transmission within the setup, the contribution of asymptomatic infections to transmission. My colleague Lorraine Kohe is going to present that. The third one is the pathogenesis question that I mentioned, who is progressing from just asymptomatic malaria to life-threatening cerebral malaria. So my colleague Carl Saido is going to present that. But we will have also a 4th presentation from Themba Nzirahowa. Basically, that 4th presentation is just looking at the interaction of the ICEMR scientists with the national platforms here, including the National Malaria Control Program, just to understand how data is passed on from the researchers to the policy makers. The team of the ICEMR in Malawi is made from people from Michigan State University, Kamuzu University of Health Sciences, University of Michigan, Boston University, and University of Maryland. All of us form the team that is called the Malawi ICEMR. With that, I think I'll call on my first colleague, Charles Mangani, to come on with Project 1. Thank you.